me, being compliant is a lot of frustration at my age, and my blood pressure is where it should be. And when I read the literature that tells me that my pressure should be at 1 level, safe, then my doctor says he wants it 20 below.
What compliance means to me? Well, there are two things. One is that you have to understand what is going on with your body, why something needs to change. And two, that you have to have sat down with somebody and have a plan of action. And compliant is following that plan of action, whatever it was. But I think just understanding what is going on with your body, why it is happening, is crucial to compliance. If you don't understand what's going on, you aren't going to follow through on the recommendations.
I don't like the word compliance because to me it sounds like a patient-child relationship. I was thinking of words like ownership, meaning the patient needs to take ownership of their condition, and there also needs to be a partnership with the physician. And I think those are really our constructive models and ways of looking at that relationship and what is supposed to happen.
That's hard to explain to every patient. We can tell them, you could have a stroke, you could have a heart attack, you could have problems with your eyes. Patients say, I know people who have high blood pressure and they're fine.
Point of fact is we are pressed for time in a primary care setting. For us to sit down for several minutes is oftentimes not an option. As soon as we sit down with one patient for a long time, the next patient gets very upset. In the future, they might have to have a nurse practitioner take them aside. In the real world, this probably won't happen. The lower the blood pressure, the better the outcomes. If they can control their blood pressure, they will probably outlive their hypertension. Hypertension, after all, is the silent killer. If a patient gets to the point where they are having symptoms, they are probably more ready to be compliant.
A patient came to me today and said, you know, my blood pressure is up because I gained 40 pounds and I'm not exercising and I'm not doing this, this, and this. Although you try to turn them around, you don't want to fix all the problems at one time. You work on the smaller things. Can you try to get exercise in twice a week? Can you try to eat out less often? Smaller goals. You're trying to teach the patient self-management so that they can manage themselves, so we are not always having to tell them what to do. It is very important that the doctor carry on a conversation with you, not come in and say, your blood pressure is high and this is what we're going to do. Just sit down and say what's going on.
I think there has to be a dialogue directly between the patient and the physician, and not with the PA necessarily, because the PA then talks to the PA, then talks to another PA, and there's going to be a broken telephone somewhere around. You have to have a dialogue with your doctor, and if you don't have that dialogue and you don't have time to do it, then there's something missing.
Interaction with your physician is an education level thing from where I'm coming from. We're all pretty well educated people here, and we probably would do these things, find out and fight with our doctor about medications and treatment plans. But if you're at another education level, you really have to lay out the plan, what needs to happen, why it needs to happen, and what this is going to do for you.
I think the emphasis generally is on drugs. What drug will do it? Maybe you have to try more exercise and diet first, and then if that doesn't work, go on medication or together with it. But I don't see that emphasis on exercise much, by anybody really, the physician or whoever is responsible.
They go to medicine first, and in a lot of cases, they need to go on medicine first, hit it with something reasonable, and then say, so, let's really find out what other things are contributing to your blood pressure.
In my case, it wasn't even suggested that I make any lifestyle changes. The first suggestion was go on a drug. It was, you need to think about going on statins. Those were his exact words. And I said, well, wait just a minute here. So I said, let me try. I've got a pretty decent lifestyle, but let me make some changes and see what happens. 6 months later, my cholesterol had dropped 30 points. That was 5 years ago, and I haven't been near statins since. But they don't suggest that up front in many cases, and I think that's unfortunate. It's a way of avoiding compliance in the first place if you're talking about a drug regimen.
But this kind of motivation could be useful to manage blood pressure. When you're at this age, do you want to continue living a nice lifestyle? The lifestyle you choose could be motivation. When a patient gives the impression they actually want to be here, they want to find out more information, they want to control their high blood pressure, they are readily able to review what was done, as is the physician. Having a discussion between two adults about a typical problem as opposed to, we're going to do this, this, and this. A mutual agreement between physician and patient, which is wonderful with any medical condition, not just hypertension. To sit down and discuss and see what's going on. Some people, they come in and their blood pressure is elevated, but they say, every time I come in here, my blood pressure is elevated. I'm rushing to get here on time. Your staff put me on the scale. I don't like my weight. And then they put me in a room and they take my blood pressure. I don't have a chance to catch my breath. Or something else. They had a car accident. They were paying bills and they had a bad phone call. As opposed to, hey, why is your blood pressure high? What are you doing? Let's discuss what is happening instead.
Some of the big 3 organizations now have contracts. Patients come in and ask for 90 days of medications. Their blood pressure is not well controlled. And yet, Company A wants us to write an additional 90 days of refills. So now we're not seeing the patient for almost a year. This really puts us in an awkward situation. Third parties are controlling many aspects of medicine now.
What we're learning is what it's supposed to look like when they walk in the door. We're supposed to engage them in what their health goals are for the visit. What are their goals? If their goal is to learn to take their meds regularly, or their goal is to exercise, we try to talk about how comfortable that goal is for them. Is it a realistic goal? Is it something that they can set? And then, how do they want to go about achieving that goal? Some people may not be ready to have any goals. Some people may have too many goals. The best idea is to narrow those goals down to something that is pertinent and related to, like hypertension.
I'm on a low dose for blood pressure. I exercise every day. I think that works for me, since that I do have some common care things I do, like potato chips, salt. It's my Achilles heel. So I try to do a yin-yang thing. It says, let me exercise and sweat it out, but I'm going to have my nuts and chips. So far, I have it under control. And again, I think our challenge is to come up with a balance with this on medication, off medication. Whatever works for you, you have to find the compliance vehicles that are actually effective and preserve that quality of life.
It's a matter of how you feel. If you feel good, your stress levels are going to go down and your blood pressure is going to go down as a result of that. I've taken blood pressure medication all my life. My blood pressure was staying pretty much the same, and I think that was because of managing stress and managing a positive attitude.
They treat the symptom, and there's not enough education on what's the cause. What is bringing on all of this? I would like to see a doctor say, you've got high blood pressure. We need to treat it. This is the medication. Here is someone to help you, a guide, a coach, if you will, on what steps need to be taken to change your eating habits, or maybe include exercise. Or they could prescribe physical therapy so that I'm coming in, so that I'm doing something and it's being monitored that way to make some sort of change.
I think one of the things they can do is use the technology to say to a person, okay, you have high blood pressure. I have this interactive quiz I'd like you to go through. Because I think if you do something like that, then it really hits rather than to have someone lecture to you about what's going on. And then send a nurse in, because physicians don't really have the time for educating the patients anymore. And another obstacle is that there are some patients that won't listen to anyone but the physicians. So the physicians have to know their patients well enough to know if they're going to be able to absorb that information from another source or if he's going to have to be the source.
It doesn't necessarily have to be the physician to assist you. If you have a care management or case management approach where you have a team coordinating for that one individual, I think the patient will get a lot more out of that. So the physician will have a part in that, and you can have better care than that. Right now, with most of the settings, that's not the case at all. The doctors go and talk to the patients, etc., and it's all well documented.
So we're talking use of computers so they can have more information at their fingertips. The use of case managers to offload some of that. I've got a doctor who uses PAs, a lot of PAs. And those PAs come in and they do all of the questioning about how you feel, blah, blah, blah. And then they go in and see the doctor and say, this is what I found out. So he can come in and in 10 minutes do the more in-depth stuff or the quantitative data gathering. It's a challenge to get patients to take their medications when warranted. And it's very distressing when the patient comes back in a month or so and you ask, how is that new medication? And they say, oh, I stopped taking it after 1 day because it bothered my stomach, but I didn't want to bother you. So, asking, are you okay with us calling you to check as a follow-up? Some people get very nervous when the doctor is calling. They think something terrible is happening. By trying to forewarn them that the office is going to call and check on how it's going with this medication has made a difference.
You always want to give people the option. Diet and exercise is always better.
Close follow-up when you have someone with elevated blood pressure. Instead of having them come back in 3 months or 6 months, have them come back in a week and recheck their blood pressure and discuss things again. For the majority of my patients, discussion is my best practice. I don't want to label you, but your blood pressure is high, and I'm concerned about it, and concerned enough to talk about diet and medication. But I want you to come back in a short period of time. I want you to feel comfortable calling me if you have headaches or blurred vision or symptoms related to your blood pressure before I see you.
I think that because in 2014 we have mandatory electronic medical records. I think that's going to help out a lot because what I've seen in patients have a whole bundle of information all ready for the doctor, synthesized when the doctor goes in to see the patient. So maybe more effective and efficient preview will help once the doctor gets a chance to see the patient. The doctor will have more information, and more accurate information might help in the actual treatment of the patient and the consultation part.
There is a disconnect when it comes to compliance. I think we all know what the problems are, but we can't do anything about them.
I think on the compliance thing too, I picked up on the partnership part and the deficiencies in the ability of the physician to be a full partner because of the demands of the patients and time constraints. But I think in terms of partnership, I think the reason it's not working, again, is perhaps because there's so little time for follow-up and so little time for additional staff to monitor that follow-up, because we know that once we leave the doctor's office, compliance becomes a greater issue, and our lifestyle sort of takes over and pulls us right back into our bad habits.
Honestly, the physicians sounded discouraged as a group. When the one doctor mentioned the chipping away with the small things first, the one thing that I liked that I heard, that was a little bit different. The one doctor mentioned the action plan, and personally I think that's a good strategy. You need to hit them with everything at the beginning and lay out the whole thing. In other words, what the consequences are and what the action plan should look like, not just the little things but the whole ball of wax. I think if they do that, then they can go home and say they've done their job. Granted, most people are going to be a little non-compliant, but at least they know what the roadmap is supposed to look like.
One of the things that I noticed is that there was a variance in terms of what the blood pressure should be. One says 140/90, another says 120/80. I talked to Blue Cross, and my wellness program is a part of my insurance, and they suggested at my age 130/80. So to me, that is quite a variation. And my cardiologist is a fanatic about the 120, and I don't think I have been at 120. It sounded like most of the physicians were all in agreement that there is a wide range of compliance. With the coordination between insurances, prescription availability, cost, diet, all of those, it seemed very consistent, I thought, with all of the physicians saying that there is no consistency.